and we really don't usually talk about the topic much. I haven't seen it really discussed here. And any physicians, anybody in the medical profession here, just curious? Well, if you were, you might not raise your hand anyways. But what I want to do is kind of give you a down-to-earthy kind of discussion about pharmaceuticals and medications and why in aviation we have to be very careful about what we take. I mean, let's face it, getting things over the counter, I mean, how can be harmful, right? Walk into the Walmart or your local drugstore, if you can buy it over the counter, it has to be safe. I mean, that's kind of the attitude that a lot of people have. And it doesn't, I know the directors say you're only supposed to take 2 of these, but if I take 4, I'll get better twice as quick, sort of attitude. Antihistamines. What can be bad about an antihistamine? After all, everybody takes it for their sinuses, right? Well, you learn that antihistamines have effects a lot of places. Some people are taking antidepressants or they're taking other medications. There's a reason why when you take antidepressants that you may get constipation as well, which really kind of sucks because now you're depressed because you can't go poop. So, I know, we're on video too, so this is going to be really funny. So what I really want to talk to you about is kind of give you a sense of how this whole system works. And of course, like any lecture I give, I like to talk about the neuroscience of it first to just give you a little background. And I know you can't read this from the back, but it's kind of interesting that, okay, so this is me being on my pedestal a little bit. My background's in neuro, obviously, and it's amazing to me the billions upon billions of neurons and connections in our body line up perfectly in each and every one of us to the point where we're sentient beings. So where we have the ability to think. And if you ever had the opportunity to see, and I hope you don't, because then you'd either be in a neurosurgical suite or you'd be looking at a loved one out in the field, which would be good. But if you ever had the ability to see a brain, it isn't this hard thing. It isn't. You can't hold it very easily, a real brain, in your hand. It's kind of goo. It's kind of this meshy, gooey stuff that's held together with a membrane. And it's not at all what you've seen in your classes when you dissect a frog or you dissect something, and it's hard little thing. It's not. It's just a pile of goo. And it's amazing how that all comes together for consciousness. And it's even more interesting if you understand the brain and the functionality of the brain, how all these little things, this idea, this intuitive reasoning that we're involved in, our ability to communicate, our ability to fantasize, our ability to create things. It's amazing how this thing all comes together. And if you're not a believer, okay, but these things don't happen by chance. And in fact, I could look at anybody's brain in this room, and we found out an awful lot about it. We know a lot of it about how you think and how you do things. This would be, in this case, the left brain. So how many of you are right-handed, by the way? Just curious. How many are left-handed? Let me tell you something about left-handed people that you didn't know. Left-handed people, a lot of people believe, myself included, that it's a function of early onset brain damage. So there we go. Raise your brain damage. Now only one's admit the other one. No, I'm ambidextrous. In fact, in the old days, we used to call it sinistrality. Because if you were left-handed, it was a sign of the devil, right? It's sinister, right? And so that's why a lot of people force their children to use their right hands, even though they were left side dominant, they were left hand dominant. And if you really want to know whether you're left side or right side dominant, shoot a gun. How do you aim? If you aim like this, with your right eye goes to the left hemisphere, your left hemisphere dominant. So whether or not you're left hand or right hand really isn't the issue. What I usually will do is, if you say you're left hand, I say, okay, show me how you shoot a gun. If they do this, then I go, yep, you're left side dominant. If they do the other eye, you're right side dominant. And that's important because that will come into play when you get older. When you get older, God forbid that you have an aneurysm and you have a stroke. Okay? A blood vessel blows because of your blood pressure or because it just gets weak. And now you have a stroke. And what ends up happening is when you have a stroke, because your brain is electrical, what happens is it short circuits, and it also is no longer, parts of your brain are no longer getting oxygen, and so they will die. And what's interesting about that is we can find out a lot about the brain. This is a brain where this would be your nose over here, and your eyeballs. This is the back of the coconut, the back of the head. And, or excuse me, I got it completely backwards. Here's the nose. I'm sorry, there's your nose. I can't even see up here. This is the back of your head. That's your cerebellum. This gives you a sense of balance. Here's your visual cortex back here. This is where things like recognizing letters, the alphabet, stuff like that come into play. What's interesting is we know that right here, this is called the prefrontal gyrus. Not that it matters to you, but this is where motor control takes place. And this is the postcentral gyrus, where you actually have sensation. So sensation is right on the other side of this big crack. This is sensation, that's motor control. If you want to know where people's thinking goes on, it's believed to occur up here in the frontal cortex. Here's where your emotions are. Sometimes some of you are accused of having no emotions. Maybe you do, maybe you don't. But if we stimulate this area, we'll find out real fast. There's a little thing in there called the amygdala that really gets you going if we get that sucker stimulated. But anyways, there's a whole bunch of stuff we know about the brain and about the way you work. That's important because brain damage does occur. People do get hit in the head. People do have aneurysms. People do have strokes. And people do have brain damage. And you have to understand what that means, because that tells us what will happen. Because if I give you certain medications, it will affect certain areas of that brain. Because actually, if we look at, as we're going to learn about neurotransmitters in a bit, we're going to find out that depending on where you're at in the brain, different neurotransmitters are dominant. So I can give you certain medications that will affect certain neurotransmitters and have very specific effects on those things. There you go. That's the extent of that. So now let's talk about the working business of the nervous system. It's called the neuron. And I'm going to show you a myelinated neuron, which we would refer to as a motor neuron. And a myelinated neuron is just a neuron with clothes on. Okay? That's essentially what it is. It's kind of like hot dogs with a bun. All right? So you've got a cell body, and all of you guys remember back in biology days. So you have this cell body with a whole bunch of dendrites, so it's like a tree, right? And it's got, this particular one has a single axon, which is like a big cable. Think of it as a cable, and this happens to be an insulated cable because this is myelin, and it's actually a silvery looking thing, whitish silver stuff. And that myelin insulates a cable so that the electrical charge can go quicker and go to the end, because this is the communication business of a neuron. This is the receiving end, this is the output. All you need to know. So these neurons, there are billions of these bad boys in there. And if you think about it, these terminal buttons or terminal boutons, if you use the neuroscience approach to it, they call them terminal boutons for some reason because it makes it sound smarter. But these terminal buttons, at the end of those, that's the working business of a neuron. And I'm only showing you this for the moment, to tell you that this is all done electrically with all kinds of chemicals. And in this case, we're talking about calcium, potassium, and ions, essentially. So essentially what you've got is an electrical potential that goes down a neuron, and you can actually record it, and I've done that. But here's what happens. So when that electrical potential goes to the end of the neuron, it essentially releases neurotransmitter. It releases some chemicals into what we'll call a synaptic space. So if you can imagine, back here again, these terminal boutons actually touch the next neuronal dendrite next to them. So if you can picture this right here, right there. So essentially what you have is these little bad boys touching on those right next to those little bad boys. If we look at the end of one of these and the beginning of one of those, you'll get this. So this is one of those terminal boutons or buttons, and what those are is they have little packets of stuff, all right, chemicals in there. And when they get an electrical potential, the stuff spills out into the synaptic space, all right? And it kind of floats across in the floaty world there, and it touches and it attaches to a receptor, all right? Very simple. So you get this little bitty piece of stuff. In this case, let's pretend it's serotonin or melatonin. You ever heard of melatonin? Yeah, right? Some of these things, you know, adrenaline, noradrenaline, stuff like that. Let's just use serotonin for the moment. Serotonin is something that's very important when we start talking about depressions. Right? And so serotonin floats across, and it touches one of these bad boys and it attaches. You can see it attaches there. And when it attaches, it opens up a little hole. So when this guy attaches here, it opens up a hole, and a whole bunch of charged particles, charged ions, float in, and when it does, it depolarizes that next nerve, and it sends its potential down the chain to talk to the next one. And why that's important is as long as that little bad boy is touching and connected, it's still doing its business. It's keeping the channel open. As soon as it falls off, the channel closes. That's important because you don't want that thing open all the time. Too much of anything is not good, right? So what ends up happening here is eventually this stuff falls away. And it kind of looks like this. If you can think of it like this, here's a little better diagram. So let's talk serotonin. So basically, coming up here, the cell body, here comes, that's my little light here, comes down, and an electrical signal comes down here, gets down here, and these little packets of serotonin get stimulated, and it releases serotonin into the synaptic cleft, the synaptic space. It then attaches itself to the receptor. The receptor then opens up an ion channel, and now all kinds of other stuff goes in here. It gets this guy all excited, so he can talk to the next one. Eventually, it's going to fall off, and it's going to do one of two things, and this is very important. It's either going to get broken down, metabolized. So in serotonin's case, it's going to get metabolized by catecholaminyl methyltransferase or something like that, or monoamine oxidase, and it's going to break it down. It degrades it, and it gets absorbed, and it gets let go. Or this is the neat thing, it gets taken back up into the presynaptic neuron. So it basically sucks it back in and puts it back in a little thing, in a little container, ready to give it out again the next time it gets stimulated. Why that's important to understand is now I can talk to you based on, if you understood that, that's all you have to understand. If you understood how it all gets released, now we can talk. Because you guys have all heard of selective serotonin reuptake inhibitors, SSRIs. Has anybody heard of those? All right? SSRIs, selective serotonin reuptake inhibitors, are antidepressants. And what they do is selectively identify certain serotonin molecules. They're selected for a certain type of serotonin, and they selectively will block the serotonin from getting taken back up into the presynaptic neuron. And when it does that, that means that you've got more serotonin in the synaptic cleft, because the only stuff that they get rid of is the stuff that gets broken down. So it hangs out longer, and it's more likely to stimulate the postsynaptic neuron. Hence, you aren't depressed anymore. Because the problem with some problem with some depressions is that for whatever reason, you're not producing enough serotonin. So if we give you a reuptake inhibitor, the stuff you are producing now hangs out longer, has a better chance of hitting the neuron, and now you're not depressed. Understood? Okay? There are other things we can give you. We can give you what we call agonists or antagonists. There are times when whatever the neurotransmitter is, well, sometimes you're getting too much of it. So what we can do is give you an antagonist, an anti. And what it does is it goes in and it goes ahead and attaches itself, but it doesn't do anything. It blocks the other serotonin from attaching. So an antagonist would go in and say, you know what? We don't want no stinking serotonin anymore. We got too much. So let's go ahead and let's give us something that will go ahead and fill that space. It'll go ahead and attach. So no serotonin can attach. That's called an antagonist. So if you're getting too much of something, I can give you something that will prevent you from it working, from the stuff that you endogenously produce. I can also give you an agonist. In other words, I can't give you more serotonin because I can't go in there and package this stuff for you, right? But what I can do is give you a medication that is a serotonin agonist or a neurotransmitter agonist, which acts like serotonin. We do this with L-dopa. So, do you know people with Parkinson's disease? Anybody know anybody with Parkinson's? So Parkinson's is a dopamine problem, where you're not producing enough dopamine, and as a result, you get intention tremor, right? So I can give you L-dopa, and it will in essence give you something artificially that will actually help, and it'll attach, and it's an agonist. So what it's doing, in a sense, is helping you out and keeping it around, or putting something artificial in there that will also stimulate that thing and it'll make it work. So we have antagonists, we have agonists, we have things that can block reuptake, and we actually have stuff that can block MAO from doing this thing, from breaking down serotonin. We call them MAO inhibitors. And we have other things that'll basically attack these things that bust up the neurotransmitter. So there's lots of ways we can play with you and play with your nervous system through medication to affect the postsynaptic neuron. That's really important to understand. I know you guys are like, okay, when does he get to the jokes? I understand that. But the point I'm trying to make is if you understand how this works, now we can have a discussion, an adult discussion, about medication. Because if you don't understand that, when I start talking about agonists and antagonists, I talk about reuptake inhibitors and stuff like that, and how that might have an impact other places in your body, it doesn't really make sense. And now we can have an adult discussion. All right? Is there any water here? Yes. Sorry about that. So let's have an adult discussion. So let's talk about the major neurotransmitters for a moment. There are a whole bunch of them. So your body is like this big pharmacy, right? And it has all kinds of stuff it produces. And the kinds of things that you might know, or may have heard of, maybe not, acetylcholine. So acetylcholine is the primary neurotransmitter at your neuromuscular junction. So the neuron that goes to the muscle tells it to move, primarily is acetylcholine. Important to know, because there are certain nerve agents that we can give you that will basically make you die because it affects the neuromuscular junction. In a sense, is a huge agonist, and it'll just make you freeze and everything spasm, like your lungs or your diaphragm, heart, your arms, everything will spasm and you can't breathe and you can't move and you die. So things like some of the poison gases we use in combat do exactly that. They affect the neuromuscular junction. There's a degeneration of neurons that produce acetylcholine have been linked to Alzheimer's disease. So we also know that there's some suggestion that Alzheimer's disease may be linked to acetylcholine neurons. So it's not just the neuromuscular junction, it's also other places in your brain. So acetylcholine is primarily a neuromuscular neurotransmitter, but it's also other places. Dopamine. We talked about how dopamine is involved in Parkinson's disease, intention tremor. It's very, very large. There's a large amount of that in the centers of your brain that control motor movement or coordinated motor movement. Excuse me. But we also know it affects your emotions. Wow. Including pleasure. Don't you wish you had some dopamine right about now? Yeah. It's been implicated in schizophrenia. So it does more. So when I give you L-dopa, it can have other effects. And we'll show you some of those side effects in a little bit. So not only am I going to be dealing with your intention tremor, but I might be also affecting other things. I mean, think about this. Every medication you take, I don't care what you're taking, and we're going to look at it in a little bit. I'm going to ask for some volunteers to give me some medications. And what you're going to find is every medication you take has multiple things it does. Those are called the side effects. So even those of you that may have Serotonin. We talked a little bit about serotonin. Serotonin, we just mentioned a minute ago, was implicated in depression, but did you also know it's involved in regulation of sleep? Well, if you sat in on my lectures last year or previous year, we talked about how serotonin gets converted to melatonin, and melatonin puts you to sleep. We also know that it's involved in dreaming, mood, eating. Oh boy. Yeah. Oh boy. Yeah, eating, pain, aggressive behavior. Wow. Norepinephrine, we all have heard how, fight or flight kind of things, parasympathetic and sympathetic nervous system. This is clearly a big thing within this sympathetic nervous system. We talk about effects of arousal, wakefulness, learning, memory. Holy cow, it does a lot of stuff. Endorphins. These are your naturally produced opiates, if you will, the pain relievers. You have endorphins in your body that help you deal with pain. And if they're not working right, we got a problem. Glutamate, number one neurotransmitter throughout the body. It's all over the place. It does everything. But lately, people have started to say, well, we think glutamate is what is involved in long-term memory. There's a lot. And when we get older, we have trouble remembering. Maybe we could do some work and come up with something that might help the glutamate receptor if we could find a specific one associated with memory. And in fact, they're trying to do that right now, and the perception of pain. GABA is largely an inhibitory neurotransmitter, but it's distributed widely throughout the central nervous system, involved in eating and sleeping disorders. So if I understand, and then glycine, if I understand what the neurotransmitters do, now we can continue to have that discussion. Because now, if you understand that every one of those things does a lot of stuff. Now when you take a medication that affects endorphins, norepinephrine, or one of those, you're not just treating the thing that you have the problem with. So let's take a peek. I know this is an eye chart. I don't want you to read the whole thing. But let's just take a look at a couple of these, just for giggles. Let's take a look at opioids. It turns out that this is a huge street drug, right? And have you guys heard of things like, I don't know, some of the painkillers out there? I'm trying to think of some of them that are on the streets, some of the street names. I'm not a drug, so I don't know. Percocet. What's that? Percocet. Percocet? Perks? Yeah, there you go. Oh, Percocet. In fact, when I did take Percocet legitimately, my wife called me Percocet because it turned me into this really different dude. And apparently I was quite in pain. And but I don't remember much about it. But these are some neat things like morphine. Oh, check this out. Morphine. Heroin. Woohoo! Yeah, there you go. Fentanyl. Fentanyl. What do we use fentanyl for? No. Okay, we use it in anesthesia and other things like that, right? Hydrocodone. Vicodin. Woohoo! There you go. Hydrocodone. Not bad. I can do that. Yeah. So these are all things that are on the street for pain, but a lot of people use them on the street for anxiety to help them sleep, right? But it doesn't. I mean, it does increase sleepiness, but in reality, it gives you a rotten night's sleep. Now, the way to do it, if people come in overdosing on these things, we can hit them with naloxone or other things to kind of bring them back. Oh, listen, here's a good one. How many of you are from Colorado? Cannabis. Weed. I love this. And here, now, I know you guys didn't know this, but it actually gives you a Taco Bell fetish. Because now you get hungry, right? Yeah. Come on, be honest with me. Who doesn't go to Taco Bell after smoking weed? Right? That's the whole idea behind the chain. No, I'm just kidding, of course. But yeah, so we've got all this good stuff. And if you really want to play a practical joke and block the effects of weed, lace it with this, Rimonabant or whatever. I don't know what it is, but it sounds pretty nasty. But yeah, then it doesn't work, right? Or let's go over here. Here's another one. Oh, I don't know. Let's take a look here at serotonin. If I give you 5-HT or serotonin, you're going to be happy. I don't know what an increase in fullness means, but you're going to be full. All right? Maybe full of it. I don't know. but a decrease in pain, because after all, you're happy, who cares about the pain? But some of the drugs that increase or mimic it, things like that, are amphetamine, cocaine, LSD, mushrooms, mescaline, SSRIs, the serotonin, selective serotonin reuptake inhibitors like Prozac, Zoloft. MAO inhibitors, remember how we said that MAO breaks down serotonin? So the inhibitors to that, there are a whole bunch, a whole class of them, will actually make you happy, right? And so we use that also as an antidepressant. Something like that. The things that are the opposite of that will make it worse are things like Risperdols, the antipsychotics, atypical antipsychotics. So these are things. So there are things that if we're trying to block the effect of serotonin, there are things we can do. If we're trying to mimic, in other words, like agonists, this is what we can do. Or if we're trying to enhance it, and this is kind of what serotonin does in general. So these charts are out there. The reason I showed you this is not so you can memorize it, but to let you know that if you get these slides, by the way, this comes from MIT, so these are pretty smart people, right? And it's kind of nice to know, because if I'm taking a medication, how many of you have taken medications and not read the insert? Be honest. Here's a better question. How many people take medications and always read the inserts? Front to back. Do you understand what you're reading? You just read it because you got nothing better to do, you're on the pot, you got to read something, right? Okay, is that what we're doing? I mean, how many of you really read them? Because here, this is scary. Think about this. You are taking medications. Most of the people, except for 2 people that raised their hand in this room, you are taking medications, you have no idea what they do. How many of you have given medications to your children? How many of you have given medications to your children and not read the insert? Why didn't I see as many hands go up? You don't want to admit it? So you've read the inserts for the children. I'm not talking about the box with the directions. I'm talking about the stuff they stick inside with all the disclaimers. How many of you have actually researched the medication you or your children are taking on the internet? Good. Good for you, because you should. How many of you rely on Wikipedia to do that? Don't. How many of you have ever heard of the physician's desk reference, a PDR? I'll show you how to get to this stuff here in a little bit. So let's take a look at some of these, because I think it is kind of interesting to look at some of these side effects. And I won't belabor this, but these slides are available. You're welcome to them, because I want to open it up, and we're going to actually get on the internet here in a minute. We're going to look at some stuff, and it's going to freak you out when you start to think about, oh my God, I've been taking that forever. Yeah. Okay, so let's take a look at sedatives. These are just a general drug class, and there are a whole bunch of sedatives a lot of you may be familiar with. Barbiturates, benzodiazepines, alcohol. We all like that one, right? Yeah. Some of you were on sedatives last night, I saw. Yeah. Some of you were very sedate. Yeah. The mechanism is basically what it does, and not that this matters to you, but it opens up potassium channels. Those channels that depolarize neurons, and anyways, it causes release of stuff. Hey, I like this major effect. Here you go, because I saw some of this. Some of you were very calm under your sedative. Some of you were a little euphoric last night. Uh-huh, yeah. Loss of inhibitions. Did anybody have any of that going down? Raise your hand. Oh, no, see, nobody will ever raise their hand on it. Oh, he just did. Oh, you scratched your head. Never mind. Talking, I like this one. Facilitates socializing, talking, singing, and sex. Not necessarily that order. And it makes you relax. Alcohol is a relaxing thing. Right. Other problems with that, so those are the side effects. Most of those we don't get too concerned with, except if you're doing this in a place that wouldn't be right. But barbiturates, let's look at this. They have the same sort of thing. Major effects, calming, euphoric, and makes you sleepy. So when you take barbiturates, generally it works on the GABA inhibitive system, and so you don't have those same major effects. But look at these side effects. Breathing suppressed. Terrible withdrawal symptoms. Death. I hate that side effect. It's very permanent. Right? How about this? Let's go look at benzodiazepine agonists, all right? Like Zolpidem. Ever heard of Ambien? Anybody heard of Ambien? What's Ambien? Sleep aids, right? Short-acting sleep aids are maybe 4 hours. All right, so the mechanism is, again, a GABA agonist. Anyways, mainly just sleepy, sometimes hallucinations. I'm kind of into that. Every now and then I've been known to hallucinate. And drowsiness, these are the side effects. Drowsiness, same as up here with the benzos. Drowsiness, falls, impaired coordination, impaired memory, and dizziness. Sound good to you? That sound that good to me. All right. So we use it for insomnia, right? Well, let's take a look at stimulants. Oh, you got to like this, right? Anybody heard of Ritalin? Adderall? That's the big one these days, right? I can tell you, as a college professor, Adderall is like Skittles to the college kids. Everybody's getting diagnosed with ADD, and they get a bucket of Skittles, Adderall, and they go for it. And they're passing it out, and these kids are using it all the time. And it's kind of scary. Methamphetamine, I've done a lot of studies with methamphetamine. I've taken amphetamine, methamphetamine, and methylphenamine. I've taken them all for great. But the truth is that they're really not good for you. Fen-phen, ever heard of fen-phen? Look in the paper, it was a designer drug that a lot of people were using. It was killing people. There's some other stuff in here you can read about. Look what happens with this stuff, with it, what it's doing. Now remember, most people take amphetamine for its stimulant properties. And it will do things. I mean, basically, it's increasing the release and inhibits the reuptake of 5-HT serotonin. And what did we say serotonin does? What was serotonin doing? One of the main things it does. Serotonin, if you don't have enough of it, you get depressed. You're Eeyore. So now if I inhibit the reuptake, keep it in the synaptic cleft longer, it's going to have kind of a euphoric. That's why if you take a lot of amphetamine, you're usually pretty happy camper for a moment. All right? Dopamine. What did we say we used? What was dopamine used in? Remember, dopamine was, where do we see? We saw a decrease in dopamine in people that have Parkinson's. Trouble with motor control, fine movement motor control, right? So the nice thing about that is it increases the release and inhibits the reuptake. So we might use some of these things to help out potentially with people with Parkinson's. That's a thought, not a great one because there are better drugs out there. Makes us euphoric, energetic, able to work, concentrate, stay awake, reduces appetite. Oh, it's an appetite suppressant. Wow, there's a thought. So I can take amphetamines, fen-phen, what they were doing, fen-phen, and it would be an appetite suppressant. But what it also does is gives you a hell of a buzz and makes you very woo-hoo, okay? But here's the flip side of it. So that's all very good, right? Let's look at the flip side. How many of you would prefer to be anxious, paranoid, psychotic, have high blood pressure, maybe a heart attack, stroke, brain damage? Wow. So our kids are taking Adderall like Skittles because it makes them feel good and happy, and they can stay up all night and they stay skinny. Wow. Here's the flip side. Nobody ever, how many of you many of you that are older, used to have 45s? You know, the 45s that you would spin on the record player? How many listened to the other side? Yeah, you always listen to the hit, right? The B side never got played, unless it was the Beatles or something. When you flip the record over, wow, this is really some spooky crap, folks. So when we have pilots taking amphetamine, Adderall, this is, yes, they stay awake. No doubt about it. They're going to stay awake. But now we have to be concerned with their blood pressure. We have to be concerned with things like anxiety. Is anxiety a problem in the cockpit? Would that be a concern to you as a passenger on the aircraft if the pilot was anxious? Yeah. Or the maintenance guy? How many of you would feel comfortable taking off in a plane where you knew the mechanic was on Adderall? Now that you know what you know. here's a good one, cocaine. Who doesn't like cocaine? Come on, right? It's a great drug. Just ask any junkie on the street. And if you don't see one, later tonight go downtown, I guarantee you'll find it. All right? Cocaine. Wow, that's a pretty cool stuff. First of all, I don't do cocaine because I have very sensitive sinuses. I would sneeze, I would blow off $1,000 off the table, and I wouldn't get it. All right? So I'm not a cocaine candidate. But if I was, let's take a look at that. So it functions the same way. It gives you a whole lot more serotonin, which makes us euphoric. Woohoo! I like it. That's why people do cocaine. I get euphoric, I'm energetic, deep and unusual thoughts. Now, you know what? I was just upstairs. One of the reasons I was late is because I was having some deep and unusual thoughts. I'm looking forward to that again. Perceived inspiration and novelty enhances sex. Everything seems to do that. Enhances sex and dancing. Now, I can dance and have sex. Music, art, touch, senses, and I'll be content. I'll be content. But think about this. The side effects ain't the same as up here: anxiety, paranoia, psychosis, high blood pressure, heart attack, stroke. But then we want to add in confusion, agitation, frequently death due to hyperthermia. You know, I was just thinking the other day, I really have always wanted to spontaneously convulse. And it's either go to Phoenix or take cocaine, right? Heart attack, water intoxication. Water intoxication. You drink so much water, you die. All right, and other problems. Oh, I'm sorry, I was on ecstasy. Oh, that must have been the cocaine I was taking earlier. But it's the same as up here, but anyways. All right. Narcotics. Now we're talking about opiates. I'll move on. Let's do pot. Let's go smoke some dope. All right, we're going to have some weed here and see how that works. Well, again, the unusual thoughts and feelings, sometimes calm, happy, hungry, enhanced appreciation of art. I like that. Enhanced appreciation of art. Now I know why I have no culture. When I walked into the Rijksmuseum in Amsterdam, I should have just got stoned first, and I would have appreciated things so much more. That's normal. Because in America, if you go to one of the coffee shops, the only people in the coffee shops are the Americans. You know, we all go there, we smoke dope, we go to the Rijksmuseum, or go see the Van Gogh. Now I understand. Now I understand. It might relieve nausea. Okay, let's look at the bad things. Memory, thinking, reflex coordination are impaired. So I'm not going to remember much. So even though I appreciate the art, I don't know what the hell I looked at. And may contribute to psychosis in the long term, and coordination are impaired. I mean, there's a lot of stuff, all right? Psychedelics. Anybody doing psychedelics, LSD, mushrooms, anything like that? No, we'll move on. Some anesthetics. Let me get deliriums. I love this one. Deliriums. Anybody use scopolamine? Anybody know what scopolamine is used for? What we use it for actually? Huh?
Outside the hospital?
Outside the hospital, yeah. Have you anybody heard of Scopodex? It's scopolamine and dexedrine, and we give it promotion signals. Yeah, did you know that? Pretty cool. Yeah. The problem with it is that it leads to loss of memory, convincing, absorbing hallucinations in high doses. We got to be a little careful. Holy crud. Benadryl. Shoot, what was I thinking? Benadryl's in that class. What's Benadryl? No. Diphenhydramine. Yeah, because think about this. Benadryl can do some pretty wicked stuff too. It has those same sorts of things: loss of memory, convincing, absorbing hallucination. Kids use it as a street drug, believe it or not. You notice how some of the pharmacies are taking it off the shelf. You can't get it, you got to go ask the pharmacist for it. Yeah. Some of the things you can have as a result: extreme confusion, temporary psychosis, hot, dry skin, dry mouth, huge pupils. I don't know about you, but I'm really turned on by huge pupils. And fast heartbeat, and of course the death, which is always a good thing. Here's some other things. Caffeine. Oh, let's just take a look at nicotine. Nicotine, I like this. Nicotine is an acetylcholine receptor agonist. Actually, there are nicotinic receptors. And there's so much to talk about, not only some of the good things, but a whole lot of bad things, that they're going to send you to Wikipedia, PubMed, or Google. All right? You just can't put it all on. But caffeine, I love caffeine. I live with caffeine. I love caffeine. Because caffeine, as it turns out, is again an antagonist to adenosine receptors, which we can talk about that another time. But it will produce alertness, wakefulness, energy, appetite suppression. Ooh, caffeine, appetite suppression, great. Headache relief. Problem is, you get insomnia, keeps you awake, right? Anxiety, headaches, on withdrawal, and diuresis, you pee all the time. We all pretty much know that, and we're living with that as we speak. So the point is that if you go back and you start looking at this stuff, no one thing does only one thing. I understand you're going to Walmart or the drugstore to get something for your runny nose. I understand that you're going to the drugstore to get something for your headache. I understand that you're going to the drugstore to get something to help you with your itch, like Benadryl. But it does other things. So when we're dealing with pilots, aircrew, maintenance people, we have to be judicious. Okay? So what can we do? This is the fun. So remember I mentioned to you, if I were you, and how many of you are pilots? Just curious. Wow, a whole bunch of them. How many of you are maintenance? How many are other type of aviation stuff? What do you guys do?
Awareness.
What's that?
Awareness.
Okay. What do you guys do back there?
Search and rescue aircrew.
Search and rescue aircrew? Okay, so your aircrew, so it's a pretty important job, right? Okay, what I saw some hands up over here. No?
Journalist.
The journalist. Oh, we don't care about you. No, we love the journalist. Of course we do. We need to alert.
Huh?
We need to alert.
Yeah.
What do you guys do? Safety? Yeah. So if you think about this, all of us have very important jobs in this room. So let's take a look. So I would encourage you strongly. You can Google PDR and you can find this. But let's go take a look at some of these, because it is kind of a hoot. And this is the way you should, anytime you get prescribed a medication or your children get prescribed a medication, go to the physician's desk reference. And let's see if I can get this to work. Give me a moment here. All right, so can somebody volunteer a medication that either they're on or that they would like to know about? Just give me one. Yes, sir. Clarity. There's a good common medication. Let's go take a look at Clarity. And so when you go into the PDR here, and let's go find Claritin. Come on. All right. It looks like it's probably going to be. I'm going to have to go a few pages here. I wonder if it can go quick. Oh, maybe I can just type it in. What am I doing? I'm an idiot. There, is it C-L-A-R-A-T-I-N? Is that right?
I think it's
I.
There you are.
Okay, Claritin. Let's just go look at it in general. All right. So now we go down to drug summary, which is always a good thing to look at. It's thinking. All right, so here is your information. It's basically, and there's other brand names. Okay, it's OTC is over the counter. That's the Drug Enforcement Agency's classification for it. Adult dosage, so it'll tell you what the dosages are if you're not sure. It also tells you the pediatric dosages. So the PDR will not only tell you what you can take as an adult, but also, and that's not always included. All right, it'll also give you warnings and precautions. So this is kind of interesting. So how is supplied, blah, blah, blah. Avoid in patients with allergic reaction to the product or its components. Caution with liver kidney disease because it has to be basically metabolized. If you have liver and kidney disease, it can cause problems. May cause drowsiness if taken more than directed. Basically, don't use it if an allergic reaction occurs, discontinue SDC. Each teaspoon contains 5 milligrams, blah, blah, blah. Okay, mechanism of action. It's an antihistamine, okay? That's nice. And there's not a whole lot else we need to worry about. So Claritin is something. It seems to function, it attacks it. Usually tells me which histamine receptor it attacks. Gives me a mechanism of action. Oh, it just says antihistamine, it didn't tell me which one. Usually it will give that to me. Let's see if it's in the related. That's your drug summary. Okay. Well, give me another one. Let's try another one. Let's see if we can find, because usually it'll give me a mechanism of action. Can you give me another one? What's that? I'm hard of hearing, I'm sorry.
Robaxacet, the muscle drug.
Robaxacet.
Robaxacet?
Yeah.
Okay.
It's a anti-inflammatory.
I got Robaxin.
AX ECET, I think, or ECET.
Let me try. So it's not Robaxin?
No,
Robaxacet. Do we have it spelled right?
it might be EC, Robaxacet, or no, ROBAX ECETA.
Let's see what Robaxin is.
Yeah, I think
See what it's used for. Muscular analgesic.
Yeah.
Okay, and it's central acting. Central acting tells me that it's working from the central nervous system. It's not working at the surface, so it's not a cream. All right, so it's working somehow. It's working internally to basically. So when I see, so that tells me that it's a muscular analgesic. So it's a painkiller. It looks like it's a muscle pain analgesic. That's what that. Adjunct relief of acute, painful musculoskeletal. Here's your adult dosage and the pediatric dosage. Contraindications: renal pathology. Where's my drug interactions? Lightheadedness, dizziness, drowsiness, nausea, urticaria, basically a rash, conjunctivitis in your eyes, nasal congestion, blurred vision, headache, fever, seizures, syncope, basically fainting, flushing. Okay, so you get very red. Mechanism of action, carbamate derivative of guanefacin. So basically guanefacin is, what do we use guanfacin for? Does anybody know? Anybody ever hawk up the big loogies out of your mouth? Yeah, it loosens them up, right? And suspected to have CNS depressant with sedative and musculoskeletal relaxant properties. So you were mentioning it was a muscle relaxant being used also as a muscle relaxant. So not only is it an analgesic, basically some pain, but it's also a muscle relaxant, right? And it's a CNS depressant, which means that it's shutting things down. In large dosages, what that tells me, that scares me a little bit, is if you take too much, you overdose on it, as a CNS depressant, so will breathing go down. So now you don't breathe. So people, and here's the funny thing. What if your kids got hold of it? It's nice to know what some of these things do so you can make sure that you keep things out of reach of people that can get themselves in trouble. Or you happen, and believe me, there are people out there, that are family members that are suicidal. This is the kind of stuff that you gotta be very careful and monitor. Give me another one. Let's try another one. Prednisone, okay? That one we're probably not gonna have a whole lot on. It's a steroid.
I'd be amazed if it did this boy.
Prednisone. I always forget how to spell it. Oh, here we go. Prednisone. Prednisone. I think it's P-R-E-D. Is that right?
Yeah.
Now let's see. There we go. Boom, boom. Drug summary. Now, if you get the actual PDR, you'll get a lot more information. So it's a glucocorticoid, adult dosages, contraindications.
There it is.
There you go.
They love to give it to people with sore joints, and man, oh man.
So let's look at that one. I like it. And I'm glad you called that one up, because this is the sort of thing that I think you should always do. Go in and look. Be a informed consumer. Rare instances of anaphylactoid reactions, basically, rarely are you going to have a reaction to it in terms of an allergic reaction. May need to increase dose before, during, and after stressful situations. May cause blood pressure elevation, salt and water retention, in other words, you get a little bigger. Increased potassium excretion, means pee's going to stink. All right. Caution with congestive heart failure. I'm not sure what HTN or renal insufficiency. Caution patients with left ventricular free wall rupture after recent myocardial infarction. Uh-oh. Yeah, so if you've recently had some cardiac surgery, probably not a good idea. May produce reversible hypothalamic pituitary adrenal axis suppression with potential for glucocorticosteroid insufficiency after withdrawal. Whoa, that's a mouthful, right? Basically, we're talking about things that are going to mess with your sympathetic nervous system. All right. Changes in thyroid status may necessitate dose adjustment, may increase susceptibility to infections, mass signs of occurring infection, activate latent disease. So if you got something hanging around, maybe you caught something when you were in the Navy years ago, it's going to come back, right? Rule out latent or active, just kidding. Caution with known or suspected strongylitis infestation, active latent tuberculosis. Oh my goodness, let's just go down to this other. Enhanced effect in patients with cirrhosis. Who has cirrhosis? Who gets cirrhosis? Cirrhosis of the liver. Commonly seen in alcoholics. Wow. May decrease bone formation and increase bone resorption. It may lead to inhibition of bone growth in pediatric patients, development of osteoporosis at any age, caution with increased risk of, oh my goodness, who would think this?
Some doctors think that this will cure anything, and when you get it,
And some people on the street do too.
yeah, and if you get these reactions, you can't just stop taking it either. You have to wean yourself off of it. It's nasty.
What I'm trying to tell you is if you do your homework, now you understand some of these drugs aren't a good idea. What I didn't do at the beginning, which I probably should have, is opened up, and we're about to look at something more important here in a second. I should have opened up and said, how many people in the room think it's a good idea for depressed pilots to take antidepressants and fly? Just curious, but how many would say that's a good idea? Now everybody says no. All right? I might have got no hands then, earlier, as well. But the point is, now you're starting to get the picture. The point is that when the FAA or the CAA or any federal agency steps back and says, can you fly on that medication? There's a reason why we caution everything. Why is it that pilots have to get an annual flight physical?
Find out what drugs they're using.
Find out what medication. And in fact, they'll tell you, most of us, particularly pharmaceutical companies, hate for you to call them drugs because it's like calling things errors, right? They're just mistakes. On the other hand, it's because the medications, we want to know what you're on. And so when you don't tell me, or how many of you go to the doctor and you're being prescribed something, the doctor says, what are you taking? Are you taking any other medications? How many of you tell them you're taking Tylenol or antihistamines or stuff you got all the time? You tell them everything? Not usually. And as a result, you're seeing all the interaction effects. So if they don't understand what dad or mom is taking, when you go in and grandpa's had a heart attack, we need to know everything they've been taking. Because if I don't know and I prescribe something, you can kill it. Yeah. Very important data point. Let me just throw one more up there. Let's take a look at a common birth control pill. Okay? Anybody have a common birth control pill? A name? Can you give me one? Anybody? I don't know. Off the top of my head. I don't think. All right. I'll look one up so nobody has to be embarrassed. So let's look one up here. How do you get a new window Go to the right.
No, where you were,
Inside your-
drug summary, the last box, you keep going. Whoa.
Oh, how cool. I have a Mac, all right? We just do a control T and we're good. Okay, so then I can click on like this. And then I can go up, where's my little plug here? Okay, so I can go up and say, can I just say, oh no, that's if you want to, how do you just tell them common, what's that? Common, or just birth control pill. Oh yeah, I know. Trust me, I started thinking as I was going. I'm just hoping. Okay, we're going to Wikipedia because you know you can't get in trouble there, right? Yeah, right. Okay. So now I come over here. Let's find one. That looks like a birth control. Where is a good one? I honestly don't know. I just thought it'd be cool to look.
There's a brand name down below that package.
Oh, there is. Look at you.
Right there. It's called
Levian.
Levian,
Is it Levian or Levian?
L-E-V-I-E-N,
E.
capital E-D.
Thank you. Let's look at that. That looks like a fun one to look at. Thank you. All right. Levian. E-D?
Yep.
That was it, right?
Yeah. I thought.
It's so good, it's not even listed. All right.
Try a less.
Try what?
A less.
A left.
A-L-T-S-S-E.
A-L-E.
The less.
E. That?
Try Yasmin.
What's that?
Yasmin.
Yasmin. I used to know
I know
Yasmin.
there was a loss in the center or something.
I wonder why these aren't working.
No.
One result. Yeah, down. You got it. There.
Ah. Okay, here we go. Finally. Sorry about that, guys. All right, so let's look here. All right, Yasmin. Okay. Warnings and precautions. First of all, let me see if it's got the mechanism of action. Well, it's just protection. Increased risk of venous thromboembolism. You know what that is? You get blood clots. Arterial thrombosis, blood clots that cause stroke in your arteries. So you've got venous and arterial blood flow. If I had to pick one, I don't want the arterial one, right? Stroke, myocardial infarction, so you can have a heart attack, right? Or have a stroke, a blown aneurysm. Greatest risk of VTE, I'm not sure what VTE is, during the first 6 months.
Venous thromboembolism.
Is that what that? Oh, okay, thank you. Venous thromboembolism during the first 6 months of use and is present after initially starting or restarting the same or different, I would imagine, the dosage. Discontinue if arterial venous thrombotic event occurs. So after the cow's out of the barn, quit using it. Discontinue at least 4 weeks before and through 2 weeks after major surgery. In other words, you tend to clot. May cause hyperkalemia. Avoid use in patients predisposed to hyperkalemia. I'm not sure what that is. May increase the risk of breast or cervical cancer. Yikes. Intraepithelial neoplasia, gallbladder disease, hepatic adenoma, increased risk of hepatocellular carcinoma, cancer. Discontinue if jaundice, in other words, you get yellowy, or acute chronic disturbances of liver function. In other words, this stuff is hard to metabolize. Cholestasis may occur with history of pregnancy-related increased blood pressure reported. So you might have increased blood. I mean, my goodness gracious. And my favorite, of course, in everything is severe vomiting or diarrhea. Nobody likes to vomit or have the Hershey squirts, okay? So the point I'm trying to make is even something that everybody takes, well, not everybody, but a lot of people take, even that I would look up. Not because I'm thinking it's I'm going to die or whatever. I just want to be an informed consumer. So how do we know then, let me get back to my, oops, sorry about that. Let me get back to, I want to throw a shout out to a group of people I met when I was talking out at Wichita at Cessna. This guy I met owns Pilot Medical Solutions Incorporated. And what he does, which is really kind of neat, there's only a few people that do this, they keep up to date on all the medications the FAA has authorized. Now, if you go to the FAA website, good luck trying to figure out everything that's authorized as a pilot. But what he does, he's a physician and a pilot, what he does is he goes in and he has this group constantly looking at this. And they also offer some legal assistance and stuff like that if you get yourself in a pickle. But this is really a neat website, so I wanted to share it with you. So here it is. And basically what you can do is you can go in and you go into their website. They tell you how they get their information. They're very upfront. You can call them. They're super people. They have aviation medical examiners there. He is an aviation medical examiner, by the way. And anyways, long story short, you can go in here and, you can actually go down, and they're all down here. So we go down. These are all the medications. I'll just go back up here. Let's go look at allergy meds. This is allergy meds. Here we go. So these are the things that have been authorized. Allergy, cold, decongestant. Sudafed is approved by the FAA, provided it is not combined with an antihistamine. They don't like you doing antihistamines. Claritin, Clarinex, Allegra are acceptable to the FAA, provide no negative side effects or experience. Vitamin B12 or other prophylactic injections are approved, provided there are no side effects. Again, anytime you have side effects, you're hosed. But basically, they're telling you what you can take. They don't want you taking antihistamines. Why don't they want you taking antihistamines? Because we can go look them up, and you'll see, and we were talking when we had the other charts, you can see all the negative things that can happen, particularly the drowsiness, right? Not to mention the memory issues and other things. Approved inhalers, Afrin, right? Flonase, some of these other things. Sedating medications are not acceptable. This includes but is not limited to Zyrtec, Benadryl. Remember we talked about Benadryl and all the nasty things about Benadryl? Yeah. Aspirin, other nasal painkillers. So, wow, sedating medications are not acceptable. Ambien. Probably shouldn't be taking that and flying, right? Antacids, you can look at some of these. But basically what this list does, what's really cool about this is, I thought, there's one, he has a site where you can actually click on these and it links to the PDR. But here's the anti-inflammatories you can take. Here's the anti-malarials, stuff like that. You can see this. There's a list that he keeps active. So if you're not sure, like Lipitor, I should have called up Lipitor as one of them. Lipitor, those are the sorts of things. These are things that a lot of people are taking for cholesterol lipid management, and these are all approved. Pending you don't have any kind of, it always says if you don't have side effects. Contraceptives, almost always approved. Cold and allergy medications, you have to take it. Depression, ooh, here we go. Depression. Celexa, Lexapro, Prozac, Zoloft are approved for pilots by the FAA on a case-by-case basis. This was incredibly controversial. This was huge because the argument was, would you rather have a depressed pilot flying or a depressed pilot on antidepressants flying? I lost the argument. I didn't think it was good to be a depressed pilot flying, period. Whether you were on meds or not, you need to get better. And, but I lost. And so I think that one of the things I would encourage you guys to do, if you are going to be using medications, check out these websites. There's a reason why we don't want people just self-medicating. And this is a really important data point, because I know a lot of people do. I get it. And how many of you, just out of curiosity, have actually random p-tests? Anybody? A few of you? The random p-test doesn't catch everything, right? We're not testing for all of those drugs. We can't possibly afford it. So you're left to your own devices. And I would submit to you that if you're taking meds without doing your homework, you're taking not only your life in your own hands, but everybody else's. And that's just not fair. And so I would encourage you to think of, when you fly that aircraft, think about driving your car with your wife and your kids in the back. And maybe you won't be as quick to get in the cockpit self-meditating. With that, I would like to take the last few minutes we have to see if I can't, hang on here, to open it up. What kind of time do we? Oh, good, we got about 15 minutes. To open it up for questions, and because I do think that some of you may have some. Hang on here, let me just put the last slide up. This is a brief review. I'm sorry. Oh, you did. Okay, I'll do it again so you can briefly review it, just in case you forgot. Got that? Questions? Yes, sir.
Do you have any thoughts on some of the medications that could be prescribed for smoking cessation? I don't have any first-hand experience with them, but I understand that they're some type of an antidepressant.
Well, even whether you're, even we see this with alcohol. So a lot of times people that quit smoking get anxious. So you're getting things like, oh, I don't know, Xanax.
Yeah, that's one.
Xanax is an anxiety drug. Xanax is one we could look up and you'll find a whole lot of bad stuff going on. Xanax is a street drug. Xanax gives you, it makes you don't even care. It makes you feel like, hey, I think you're not anxious, you're not in a hurry. If you ever talk to somebody on like a full Xanax, it's a true serum. So if you really want to know, give them some Xanax. And because you just don't care. Now, is that the person you want to fly? So a lot of alcoholics, they'll prescribe Xanax or some sort of anti-anxiety drug. That whole class of drugs has a very nasty side effect. And I think I get very nervous personally when I start seeing people prescribing that in high-risk industries like aviation. And when I say high risk, I don't mean high risk like you're going to die. I mean where the potential for mistakes is very high.
Where the potential is if somebody goes to their family physician because they want to stop smoking
It doesn't tell them they're a pilot. And I don't think it's so much airline pilots. I really don't. I think airline pilots get it, and that's something we do test for, is if you're on an anxiety drug or you're taking something that you shouldn't be. And by the way, they sell that stuff on the street. I didn't even know that, but they're called Xan bars. I thought, what's a Xan bar? It sounds like something you buy, it's a candy bar. No, it's a full Xan that you can buy on the street for about $7. And it's a really, it disarms them out. And kids love this stuff. But it makes me nervous because the other thing I didn't talk to you guys about, but here's the funny thing about your body. Your body is a homeostatic mechanism, which means what that says is the body is used to producing a certain amount of different types of neurotransmitters. And whenever you give something, if you artificially enhance that neurotransmitter by blocking reuptake or blocking the things that will break it down, metabolize it, or if you produce artificial of that neurotransmitter, what is the body's response going to be? It's going to throttle back and quit producing it because it's going to try and reach an equilibrium that it's decided on. And so what happens is when you start taking Xanax or things and you do things artificially, or an antidepressant, when you do things, and dopamine, L-Dopa. If I give you L-Dopa for Parkinson's, it doesn't last forever. It's a last-ditch thing because it'll last for a few years and then it won't work anymore. Because basically the system will adjust, and when it adjusts, you can get all the L-Dopa in the world won't matter. And so it's kind of a last-ditch effort. So be careful. That's where addiction comes in. So yes, sir.
For the pilots in Colorado, I think maybe Oregon is legal now too. My understanding of alcohol is that my body will clear that out at 0.15 milligrams per hour. I also hear that there's a half-life for THC.
Absolutely there is. That's why you get busted.
So, and that when THC is stored, it's in the fat of your brain or so it's stored in the fat.
It's not in the brain, not in the fat, really it is, but you have a story.
So if you're just a one joint a weekend guy,
Well, two things. Number one, I appreciate the fact that you didn't preference with, I have a friend. I love that, you know, it's not me, but I have a friend, and, but no. But, you know, there is, and again, I don't even smoke weed, I don't do that crap. But I have a friend that does. No, I will tell you that if you're smoking a joint a week, we're having a long discussion. I mean, the discussion should be really why you need that. If you're only smoking one joint a week, what's the point? And so, and I honestly don't know people that only smoke. It's the weed, all right? That only smoke one joint a week, but because usually when they tell you one, it's or more. But the THC doesn't build up and like keep building. You have to smoke a lot, all right? Now, it does stay, and you will get it detected in the blood. It stays in your system. There is no patent running. But I think the large problem for me is the person is smoking a joint on the weekend. It's kind of like alcohol. I've always been of the impression, when I used to, and believe me, everybody that knows me here knows I was a heavy drinker. I've been sober for 4 months. I am a heavy drinker. And I'm different. I feel different. But the thing is that I used to go around lecturing at squads and talk to cops and say, listen, the 12-hour bottle rule is sacred. And I always got a comment like, well, you're telling me that I can't even have a glass of wine with my wife at dinner if I'm on the flight schedule at 7 in the morning, and we're eating dinner at 9. I said, well, I hear what you're saying. He said, well, won't the alcohol be cleared if I'm only having a single glass of wine? The answer to that question is yes. The answer to that question is one glass of wine is not going to affect your performance the next morning. The bigger question is this: how badly do you like to fly? If you love your job and you love flying, and you just simply can't give up that glass of wine that night with your wife at 8 o'clock, because by golly, I have to have that glass of wine, you have a bigger problem that we need to discuss. So I would go back to a pilot that's smoking one joint every Sunday and ask, why? What's your point? And I don't think it's going to have an impact long term. Other questions? You're right.
You mentioned in the discussion potassium. So have you looked at any supplements and the downside?
I knew you were going to ask. Somebody was going to ask that. This is a study we're doing right now. Let me just tell you guys, how many of you actually drink energy drinks? Just curious. I'm a Red Bull-aholic. I've been going cold turkey up here because I can't find Red Bull in this hotel, and it's driving me nuts. So I've been drinking Coke Zero like it's getting out of stock. And so I drink Red Bull all the time, which is really bad. I do 5-hour energy drinks, those little 5-hour energy deals. You ever done those little shot things? We're finding out that's bad juju too. The stuff they put in those, like, what is Monster drinks? I can't remember them all. So what we're doing, I'm teaching a neuropharmacology class this semester for Neuroscience. And as their final project in 2 weeks, the teams all have to bring in 2 energy drinks and go down and give me the whole list of all the bad things there. The reason I'm doing that is I want to know. Because I never looked it up and I don't have your answer. But that is something, we're seeing kids do these things all the time. They're drinking them like soda pop.
Well, they're mixing them with alcohol.
Well, yeah, that's how I got my first Red Bull, with Red Bull and vodka. I thought my heart was going to explode, but I didn't care. So, you know, I think that's the thing. They're mixing them with alcohol, they're mixing them with all sorts of things, and they're drinking them all day long. They're drinking them in school. I'll see them in my class, and they've got a Red Bull right there. Now, I'm guilty, I do too, but I want to know, and we're going to find out they're really bad. They're really bad. Other questions? Yes, sir.
Just to take up on the energy drinks or all the Mountain Dew, that type of double, triple caffeine routine that the teenagers dealing with this with a grandson and the mother who's oblivious. But it's the amount of sugar that's pumped in there on top of everything else
I think there's, in fact, there's been a few studies suggesting that you're probably better off doing the full flavor ones because of the aspartame.
Well, yeah, we're
And
gonna
sad.
try either way.
It's just, you know what? There's a reason why you shouldn't be doing that stuff.
Yeah, but I would just question the amount of sugar and fat. They're probably killing the taste of sugar or something.
Yeah, I don't know. It's
Other
really
effects
scary.
are good.
Yes, sir.
When I look at this kind of picture, and I say to myself, our random drug and alcohol testing programs, like what percentage of that are we catching? And what percentage are, you know, the young generation saying, well, I can take this, this, and this, and I know I will fail a drug test.
You can, for example, though, how many of you have actually looked at like, and I know not this is canon, but a CAA or an NTS, or what was it, TSB or the NTSB action reports where they have the tox screen. Have you ever seen a tox screen?
Yep.
They like an accident, for an accident. I mean, it's fatal. If you get like in the U.S., if you get the docket, you'll get the toxicology report, which will tell you a list of what they're really looking for the majors. They're looking for antidepressants. They're looking for cocaine, the street drugs. They're not looking because they can't afford it. I mean, the screen itself. I mean, to run it through all that, it's very expensive. And so what you're finding is that more often than not, like in the military where I was, in the Navy, they're looking for THC, they're looking for cocaine derivatives, they're looking for things that are normal street drugs. They're not looking for things that are necessarily prescriptions that people aren't interested in. They're not looking for virgin pills. All right? So they're looking for things that are going to be mind or mood-altering drugs.
And what are the effects then of mixing some of these things too?
Oh yeah, it's
So the solution is you call your medical physician, your transport physician, and ask before you take it.
you would be amazed at the things that kids have found that they can sniff, ingest. I mean, when we were growing up, it was about glue, and we talked about glue heads, and I was Elmer's glue, and no. Elmer's glue, I just stick it to my nose, sort of thing. I mean, these kids, or how many of you, when you were kids, like nitrous oxide, you got the balloons and stuff. That was peanuts compared to what they're doing today. These kids are little chemists. They're very smart. Everything's on the internet. You'd be amazed what you can do to make your brain go jump. And it's very unfortunate. It's very sad. I want to thank you for your time. I want to thank you for coming. I want you to enjoy the rest of the day. And I've got another talk in a minute on point of view. Thank you very much.